Welcome, everyone, to the All Things Celiac webinar series. Today's webinar is titled, Is it Celiac Disease or Something Else? Or Something Else Entirely? SIBO, IBS, and Other Intestinal Disorders. It is hosted by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. The Harvard Medical School Celiac Education and Research Program was founded in 2013 by celiac experts from 3 Boston hospitals: Dr. Alan Leichner of Boston Children's Hospital, Dr. Kieran Kelly of Beth Israel Deaconess Medical Center, and Dr. Alessio Fasano of Massachusetts General Brigham Health. The highly collaborative Harvard Medical School Celiac Education and Research Program has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. My name is Chris Rich, CEO and Executive Director of the National Celiac Association. The National Celiac Association provides educational resources to our celiac community, such as this All Things Celiac webinar series, our Feeding Gluten-Free program, which has delivered gluten-free food to food pantries in over 3,000 communities across the United States, and our new mental wellness initiatives. Our extensive support network reaches from coast to coast and assists everyone from kids and their families to our celiac seniors. You can find more information about these and our other programs on our website at nationalceliac.org. For today's event, you're welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. Closed caption is available by clicking on the CC button, also in that bottom menu. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org. That address again is digitalmedia@partners.org, or you can reach us by phone at 857-282-6470. This session is being recorded and will be available for viewing on the National Celiac Association's website. That address again is nationalceliac.org. Our moderator today is Dr. Catherine Olshan. Dr. Olshan is a pediatric gastroenterologist at Mass General for Children. She serves as an assistant physician at Massachusetts General Hospital and as an instructor at Harvard Medical School. She is a member of the Center for Celiac Research and Treatment at Mass General for Children and is involved as a sub-investigator in multiple clinical trials, currently enrolling participants with celiac disease. In addition to her medical degree from Medical College of Wisconsin, Dr. Olshan completed her residency in pediatric medicine at the University of Massachusetts Medical School, UMass Memorial Medical Center. She also completed her fellowship in pediatric gastroenterology at Mass General for Children. So let's get started, and by saying welcome, Dr. Olshan.
Thank you for that kind introduction, Chris, and to the NCA for having me here today. Again, I'd like to welcome everyone onto our webinar, which is titled, Is it Celiac Disease or Something Else Entirely? We'll be discussing SIBO, IBS, and other intestinal disorders. Again, as a reminder, the Q&A feature is in the bottom right corner, and we invite anyone to submit general medical questions, but ask you to refrain from submitting specific medical questions. Tech support is available throughout this webinar. You can either call our number at 857-282-6470 or email at digitalmedia@partners.org. The session will be recorded and be available for viewing later on the NCA website, which is nationalceliac.org/webinars. And that 1.52 CEUs are available for registered dietitians, physicians, and social workers who have pre-registered for the webinar. But to receive these CEOs, you must fill out the survey, and we'll post that link in the chat section. So without further ado, I'd like to introduce our first speaker, which is Dr. Amelie Therrien, who received her MD in 2011 from the Université de Montréal and completed her internal medicine residency and then her adult GI fellowship combined with a clinician scientist program in 2017. She is a fellow of the Royal College of Physicians of Canada in internal medicine, adult gastroenterology, and a clinician scientist. She completed a master's degree in experimental medicine with a focus on immunology, working in Crohn's disease in 2018, and then moved to Boston to study celiac disease with Dr. Kelly and the Celiac Research Program at Harvard Medical School. Her main areas of expertise are celiac disease, other small bowel disorders, nutrition, and inflammatory bowel diseases. She is now working as a clinician scientist at the Celiac Center at Beth Israel Deaconess Medical Center and as an instructor in medicine at Harvard Medical School. Thank you.
Yes, thank you very much for the invitation to speak today. I'm very excited by this topic. I get so many questions from patients about this. So let me just move along. Okay, so here are my disclosures, but none related to this talk today. So today we will answer the following questions. So what are the causes of new or persisting symptoms after starting a gluten-free diet? And what are the other causes of having elevated anti-TTG or villus atrophy that are unrelated to celiac disease? So I want you first to understand how a normal intestine works. So the intestine is like a big shaggy rug, like you can see on the left. It's a picture with an endoscopy where we see all the little villi. There are billions of small finger-like projections like that, the villi. And each villi has a micro brush border that is like kind of like little cones, little strings. And on these borders are enzymes that complete the digestion, because you have first your enzymes from your stomach, your pancreas, your liver, but there are also little enzymes in the intestine that finish up the digestions of sugars and proteins. And finally, your intestine is also filled with healthy bacteria. However, in celiac disease, there is inflammation that makes the villi being shrunk, as you can see on the left, compared to the initial healthy intestine. This makes a loss of the absorption surface, but also you lose the brush border enzyme because you do not have those little like finger-like projections anymore. So there is maldigestion and also malabsorption. And to still have sugars and some proteins that are not fully cut down in your intestine cause fermentation by the bacteria. And the gas can cause distension of the lumen of your intestine that cause pain, bloating, flatulence, diarrhea. There is also sometimes a change in the type of bacteria that are in your intestine when there is inflammation, and they may proliferate in large amounts. As you know, in celiac disease, you can have symptoms that involve your GI tract, like abdominal pain, bloating, diarrhea, constipation, nausea. But other people are also having some symptoms outside of their GI tract, like joint pain, headache, muscle pain, mouth sores. So it's associated with both. In general, GI symptoms start improving after a few weeks on a gluten-free diet. But the extraintestinal manifestations, such as fatigue, for instance, can last over 2 years. And here are data from the Celiac Center in Chicago that shows that some extraintestinal manifestations, such as having like abnormal liver enzyme, having rashes, having hair loss, may have a higher chance of resolving. But as you can see, it can take like more than a year, 2 years to have some resolution. Muscle pain, fatigue, having a poor mood, joint pain are not necessarily resolving on a gluten-free diet. And it's possible that these symptoms are not caused by active celiac disease or gluten exposure. So when symptoms are not improving, the first question is, have we waited long enough? As we do not expect that everything will resolve instantly on a gluten-free diet. Like it takes time for the intestine to grow back, to heal. The other question is, were all of the symptoms really caused by having celiac disease, or was it something else? For instance, acid reflux is very common in the US, and some people may have this independently of celiac disease, and this will not improve on a gluten-free diet. This will improve with anti-acid medications. The other questions are there unsuspected gluten exposures? And we usually repeat the blood work, expecting that the serology, the TTG, will be trending down. We recommend to meet with a dietitian. And in some cases, we consider some commercial urine or stool tests to look for recent gluten exposures. We discussed that celiac disease was associated with inflammation and having a flattened villi intestine, like we see on the right here. This takes time to heal, and independently of being on a gluten-free diet, people may have symptoms for a while due to other food that are either not well absorbed, digested, or both. Common examples include fructose, lactose, sucrose, and Christy will discuss that further in the following talk. We also see that cutting out gluten may lead to more drastic dietary changes. For instance, some people may add more chickpeas, beans, cauliflower in their diet. This combined with the change in the bacteria may cause additional bloating, flatulence that the dietitian can associate with certain foods while she or he is working with you. Constipation is also quite common. Either it was already there before the diagnosis and did not improve, or it developed due to the gluten-free diet being poor in fibers. Constipation has several definitions. It can either be having fewer than 3 bowel movements in a week, having stools that are hard, dry, lumpy, having stools that are difficult or painful to pass, or having a feeling that not all the stools have passed. It can also cause diarrhea, as pictured on the right here, when some large stools are stuck and above there are some soft stools. At some point, the colon may start to strain and the loose stools goes around the hard stools, and the person is only having like shredded stools and still feels uncomfortable. And in general, constipation may cause bloating, abdominal cramping, nausea. So these are all symptoms that sometimes may be felt to be like, oh, is it active celiac? But in fact, the person is having constipation. SIBO, small bowel intestinal bacterial overgrowth, happens where the bacteria proliferate in your small intestine. Usually a normal intestine has some defense and fight back to control the type and amount of bacteria. But in celiac disease, they may proliferate more than they should. And this can cause fermentation of the food. This can inactivate some of the enzymes and worsen the maldigestion. So the symptoms also include nausea, abdominal pain, bloating, flatulences, diarrhea. It is diagnosed with a breath test. We usually recommend a glucose breath test, and the breath test should test for hydrogen and methane in your breath. Another concept involving the bacteria is dysbiosis, which means to have an imbalance between the good and the bad bacteria. It may also cause bloating, flatulences, and a form of like IBS with a diarrhea predominant type. Pancreatic insufficiency is controversial in celiac disease. Theoretically, we know that the enzymes may be inactivated by the SIBO, like I just said. They may also fail to activate themselves due to the villus atrophy that reduce the enterokinase that is needed in the process. So as pictured on the right, on the tip of your villi, you have enterokinase that kind of like activate the pancreas enzymes. And when you have villus atrophy, you may miss that factor that is helpful to activate the enzymes from the pancreas. There are no evidence, however, supporting that over-the-counter digestive enzymes in celiac disease are necessarily indicated, beneficial for everybody, but we prescribe supplemental pancreas enzymes if we confirm that there is an insufficiency with a stool test, for instance. So after 1 year on a gluten-free diet, if there are still symptoms that are unexplained by the causes we just discussed, we can proceed with an upper endoscopy and duodenal biopsies to see if there's still villus atrophy or there's still of active celiac disease. If the biopsies are normal, we go back to the initial causes I just mentioned, but we may also consider a problem outside of the intestine, such as, is it mostly the esophagus? Does the person has reflux, esophagitis, eosinophilic gastrointestinal disorder, which is another type of immune-related involvement of the GI tract, Crohn's disease, and also microscopic colitis if the person mostly has diarrhea that is ongoing despite the gluten-free diet. So I would like to briefly talk about the microscopic colitis. It is associated with celiac disease, and for some people, in general, it's overall a rare condition. And in celiac disease, it's about 86 per 100,000 person years that will develop microscopic colitis. There is no visible inflammation in the colon when you have a colonoscopy. So the GI doctor really needs to do biopsies of your colon to diagnose the disease. It's mostly lymphocytic, meaning that there is more lymphocyte in your colon. And sometimes there could be collagen bands also seen on the biopsies. It causes chronic non-bloody diarrhea. If there's blood in your stools, it's not microscopic colitis. And it may be found at the time of the diagnosis of celiac disease and improve by itself with the gluten-free diet. Otherwise, if it doesn't improve going gluten-free, we need to add medication to help the person, such as budesonide. If we still find inflammation, going back to the initial algorithm that you're still having symptoms after starting a gluten-free diet, it's been a year or so, we repeat the duodenal biopsies and we still find inflammation in your biopsies. The first question to ask ourselves is it overall better than at the time you were diagnosed? It can take many years for the intestine to fully heal, and sometimes it takes longer the older you are. So if you have a biopsies, let's say 1 year or even 2 years after the diagnosis, and there's still a little bit of villus atrophy, but at the time of your diagnosis, you had like complete flat villi, it's still an improvement. It still shows that your intestine is getting better. We always dig more for gluten exposures, which is a very, very common cause of still having symptoms, still having inflammation in the intestine. And the other question we ask ourselves, and this is in collaboration with the pathologist to look for other like features on the biopsies, is, for instance, is it acid related? Because sometimes the first part of the small intestine is exposed to the acidity of the stomach, and there are changes that may look like inflammation, but it may be only because of the acidity of, mostly because of the acidity of the stomach. And we also ask ourselves, is there an overlap with other form of like infectious or inflammatory conditions, such as autoimmune enteropathy, tropical sprue, chronic variable immunodeficiency, collagenous sprue, Crohn's, eosinophilic gastrointestinal disorders. But that we should discuss with a GI pathologist looking for other features than celiac disease. And it's overall very rare to have those added conditions. So to summarize the first part, not all the symptoms, gastrointestinal and extraintestinal, present at the time of your diagnosis are necessarily caused by celiac disease and will improve on a gluten-free diet. Time will tell, mostly for the extraintestinal manifestation, whether or not this was something that was gluten-induced and gluten-responsive. Some symptoms are caused by having damages in the small intestine and will progressively improve with resolution of the enteropathy, but not as soon as you go on a gluten-free diet. And some symptoms are linked to the changes in the diet composition because you're adding more like high FODMAP things, or you're having less fibers and then are more constipated. So it is critical to work with a dietitian to assess the diet also beyond the gluten-free diet. It's important to be mindful of your bowel movement. Do you have symptoms of constipation? And also to reconsult a gastroenterologist to assess the other medical causes would be very useful. So the second part of the talk is to discuss what are the other causes of elevated tissue transglutaminase antibodies or villus atrophy that are unrelated to celiac disease. So the definition of celiac disease is to have some inflammatory reaction in your small intestine because you're ingesting gluten. And it usually presents with having a positive blood work and some inflammation that is seen in the intestine when we take biopsy. So usually it's the two conditions that are combined that make the diagnosis for celiac disease. We are looking for in the blood work for antibodies against the TTG, which is an enzyme that changed the configuration of gluten, and the immune system recognized it bound with gluten and develops antibodies against it. So in the figure here is the purple and yellow thing, a complex between the enzyme and the gluten. However, this enzyme is not only in your small intestine, and it doesn't only process gluten. It processes many other proteins, and it is found in almost every organ of the body. And some people, we find in some people some antibodies that when we test them in the lab, they are identified by the assay as being like anti-TTG. But the person may be having some hyperactive, non-specific immune response with having lots of like antibodies in general in the blood, and there is a cross-reactivity with the assay, and it is interpreted as being anti-TTG as if it was celiac disease. It can happen with some inflammatory process in organs that also have TTG, like we saw in the last slide. And some infections like GI infection, mononucleosis, H. pylori have also been reported to be associated with some antibodies against the TTG, but this is not celiac disease. And so we may find mild elevation of the antibodies in several other like autoimmune inflammatory conditions. We can sometimes find that in Crohn's disease, in rheumatoid arthritis, in lupus, that there are some circulating antibodies that are kind of like identified as being the TTG, but it's not related to celiac disease. And also in other liver disorder, we can find mild elevations of those antibodies. However, if the person is having a very, very high elevation of the serologies of the antibodies, more than 10 times the upper limit of normal, it's very more likely to be celiac disease with a positive predictive value of almost like 100%. So to really know what is going on, it's important to look at the intestine when you have positive blood work. Because if you have positive blood work and positive biopsies, then yes, it's a diagnosis of celiac disease. If you have positive blood work but normal biopsies, this may or may not be a diagnosis of celiac disease. You may be having TTG that are elevated because of another cause, like I just mentioned, a false positive. You may be having potential celiac disease, meaning that, yes, there are antibodies against gluten, but there is no inflammation yet in your intestine. But yes, that could develop into celiac disease. Sometimes also for many reasons related to the procedure, the GI doctor was unable to take a lot of biopsies of the small intestine. And if only like 2 biopsies, let's say, of your intestine were taken, this may miss celiac disease. Like we know that the disease is patchy and there will be a higher likelihood of finding the disease if the GI doctor takes about 6 biopsies of your intestine. And so in case of doubt, we also do some gene testing for celiac to see if the person is carrying an HLA DQ2 or DQ8 that is associated with celiac disease. And if not, celiac disease is very unlikely. And the same happens upon follow-up on a gluten-free diet. If some people may still be having like mildly positive TTG, but normal biopsies. So this may not mean necessarily that your celiac disease is active and you are not following a gluten-free diet well. Your biopsies are normal and you're still having a little bit of elevation of your TTG. This may mean that there could be another inflammatory process, like I mentioned in the slides before. And this can also, in some people, just mean that it's your new baseline. Like we find in a few people that they never fully normalize their TTG. They are always like a little bit like above the limit of normal. So I would say, in case of doubt, to repeat the endoscopy and take multiple biopsies of your small intestine will give an answer as to whether or not the blood work is really related to an active celiac disease or not. And the last minute of the talk will be about talking about biopsies that look like celiac disease. When it is at the time of the diagnosis, if you have like no positive serology, like normal TTG, but biopsies that show inflammation, this is called a seronegative enteropathy. Seronegative means no antibody. And the most common cause of seronegative enteropathy is still celiac disease. Some people with celiac disease have low total IgA, meaning that they are not producing a lot of the antibodies that are associated with celiac disease in general, but they still have the disease in their intestine. Some people may already be on a low gluten diet, and then the blood work is like not super reliable, but we're still finding damages in the intestine. And sometimes some people are it's just the way their disease is. They are not producing antibodies, but they have some inflammation in the intestine that respond to gluten. The other possible diagnoses include some infections, some other inflammatory and autoimmune disorders. Some medication can cause some damages to the intestine. SIBO can cause some mild damages like mild inflammation, mild villus blunting. So your doctor needs to work with you and the pathologist based on other like clinical like history that we may have, and also other signs on the biopsies. So, and at the follow-up, if you have a diagnosis of celiac disease and you're still having inflammation on follow-up biopsies, It can, like I mentioned at first, like it can still be that your disease is slowly improving, that we took a biopsy, but it was only like 1-2 years after the diagnosis, and that the intestine did not have the time to fully heal. It can be another diagnosis, or people are very concerned about refractory celiac disease, but this is overall very, very rare. I would say less than 1 over 5,000 patients with celiac disease will have refractory celiac disease. And so we go back, like I mentioned at first, when we have like a patient that is on a gluten-free diet that are still having positive biopsies, we go back to those causes and work with the pathologist to see, is there an overlap with another condition, or is it celiac disease that is slow responding or having still gluten exposures? So to summarize, the diagnosis of celiac disease should be made with both positive blood work and biopsies, except in specific scenarios where the TTG are very high and we are unable to proceed with an endoscopy. The TTG may be elevated with other inflammatory conditions. The biopsies may also show inflammation unrelated to celiac disease. So it's, in general, it's to really confirm a diagnosis of celiac disease, you should have positive blood work and positive biopsies. And if it's not that combination, then dig further and work with the doctor to see if there could be another cause. And like I just said, in case of doubt, do not hesitate for a second opinion and go to a center where there would be a GI pathologist that will dig further in with your biopsies and have a thorough evaluation of that. So this is what I had, Catherine.
Perfect. Thank you so much for that comprehensive overview and for getting us started today. I'll now introduce our second speaker, who's Christy Moran, who's a registered dietitian and licensed nutritionist. She was diagnosed with celiac disease when she was 3 years old and inflammatory bowel disease when she was 31 years old. She has over 17 years of clinical experience and a lifetime of personal experience, and has worked in private practice for 5 years, offering a personalized and extremely supportive approach. She specializes in gastrointestinal disorders, including IBS, SIBO, IBD, disorders of the gut-brain interaction, celiac disease, and other gluten-related disorders. She received her undergraduate degree in human nutrition from the University of Massachusetts Amherst, completed her dietetic internship at Beth Israel Deaconess Medical Center, and her master's degree in human nutrition from Framingham State University.
Hi, everybody. Happy afternoon. So let me just bring up my slides. Sorry, I'm having somebody else advance them because we had a little trouble. So I'm Christy Moran, registered dietitian. I'm just going to be talking about the dietitian's perspective of what we do if someone is still having symptoms. So next slide. So I have no disclosures. So the very first thing that I will do when I'm meeting with a patient is ask all about their adherence to a gluten-free diet, because we know that the number one reason for someone not responding well is that they're either getting gluten exposure accidentally or very rarely, but sometimes intentionally. And that is 35 to 50% of patients. That's the main reason for ongoing symptoms. So the American College of Gastroenterology has guidelines, and 2 of their guidelines are really making sure that ongoing gluten ingestion is excluded as a possible cause, and then having a complete nutritional assessment to look at other nutrient deficiencies and other possible causes. Next slide. So the ways that we can assess with this is we assess for any possible gluten ingestion. On the next slide, I'm going to talk a little bit more about that. and then assess for other possible food intolerances as well. So as was mentioned earlier, there can be other intolerances, sometimes due to the lack of enzymes that are being produced. So lactose, fructose, sucrose, some of the other FODMAP foods, and then assessing some of the symptoms and medical history. And by doing a really deep dive into a diet history, I'll be also thinking about some of these other possible food intolerances while I'm asking about possible gluten ingestion. And that's really helpful to be able to see, okay, is there a possibility that there may be other intolerances going on as well? And then also part of this assessing for malnutrition, sometimes that can be a part of the ongoing symptoms as well. And then always coordinating with primary care, gastroenterologist, mental health providers, and any other provider they're working with. Next slide. So like I said, the number one thing I'm always starting with is making sure that somebody is adhering to the diet. And this list is not comprehensive, but this is some of the important ones and some of the ones that people don't think about as well. So the obvious of, do they know how to read a label and look for ingredients that contain gluten? Are they potentially getting cross-contamination from a kitchen that somebody else that might be eating gluten in that kitchen? Looking at things like, are they consuming communion wafers? Are they consuming reduced or removed beer? And then what are the barriers? Are there any barriers to sticking with a gluten-free diet? And sometimes that's all we need to do to help. Next slide. So as this was listed before, some of the other possible causes of ongoing symptoms can be inflammatory bowel disease, pancreatic insufficiency, sucrose isomaltase deficiency, and then other possible carbohydrate malabsorption. So like we mentioned with the lactose, fructose, fructans, other FODMAPs. Sometimes a change in fiber is one of the things that can cause those, the overlap of irritable bowel syndrome, and then SIBO and or intestinal methane overgrowth. Next slide. So first we'll dive a little bit into some of the diets that are out there for irritable bowel syndrome. So up to 85% of patients with irritable bowel syndrome report that they have food-related symptoms. So of course, we're going to think about diet as one of the treatments for this. So the AGA clinical practice guidelines that were just updated in 2022, they do recommend that patients discuss this with their provider or dietitian prior to starting any diet. So especially thinking about who's a good candidate for possibly other dietary modifications, because we don't want to cause any more harm by removing more foods for maybe someone who has a strong history of an eating disorder or somebody who is food insecure. We have to take that into consideration before deciding on any other possible dietary changes. And then we always talk about how long, if we're going to do an elimination diet, how long we're going to do it for. So I find what's really important in practice is if we're going to do an elimination diet of, let's say, fructose, we're going to talk about a predetermined length of time that we're going to try it. If we don't get any clinical response, we're going to change the treatment. We're not going to stay on that diet long term. And that can be really helpful for people to know, okay, I'm going to try this for this amount of time. We're going to reintroduce at this point, and the reintroduction is really important if they don't have any response to it. Sometimes it's changing different types of fibers, sometimes it's other diet modifications, and we'll talk a little bit more about the low FODMAP diet and the NICE diet, which is from the National Institute of Clinical Excellence from the UK. Next slide. So these are the NICE diet guidelines. And again, these are from the UK. So they are a bit more basic than some of the other diets that are out there for IBS, but also the reason that I'm talking about this today is because it is preferred by a lot of people because it's a little bit easier to implement. So number one, having regular meal consumption. So not going long periods of time without eating, having well-balanced meals, adequate hydration, limiting carbonated and alcoholic beverages, and then reducing the intake of certain things. So caffeine, certain types and amounts of fat, not having excessive amounts of fruits, and if diarrhea is present, not eating as many of the skins. Sometimes it's about modifying the way a vegetable is cooked, and sometimes that can be helpful. Reducing the intake of some of the resistant starches, so some of the gluten-free whole grains, sweet corn, rice bran, green bananas, things like that. And then some of the gas-producing foods, especially added sorbitol, and an example of that would be in a lot of gums. So sometimes that's a place that we can start, see if those adjustments make any difference before moving on to a potentially more restrictive elimination diet. Next slide. So the low FODMAP diet is something that potentially many of you have heard about. This diet is a very restrictive diet. It is supposed to be done in 3 steps. FODMAP stands for fermentable, oligosaccharides, disaccharides, monosaccharides, and polyols, and those are all short chain components of carbohydrates. So as we've mentioned a few times, lactose and fructose, those are considered 2 types of FODMAPs. So the diet is done in a 3-step phase. The first phase is a low FODMAP elimination diet where we swap high FODMAP foods for lower FODMAP foods. And the reason I really want to drive home the swap part of this is that that's really important, that we're making sure that people have some other food to swap something with. So if we're taking something out, we're putting something else back in. So the diet is as least restrictive as possible. This phase of the diet, it is also short term, so up to 6 weeks. And that's something, again, with every single one of my patients, I make really clear, because very often patients have a challenging time starting to add things back in or being on it for a prolonged period of time, which we don't want someone to be on a more restricted diet than they have to be. Next phase is the reintroduction. This can take anywhere from 8 to 12 weeks. We introduce 1 FODMAP at a time over a 3-day period and assess the tolerance to that. And then the third phase is the personalization phase, kind of moving away from following a list and more towards exploring what portions of foods work for you. If we know 1 or 2 categories that you don't tolerate well, sometimes we can play around with, is a small amount tolerated versus a large amount, and modify it so that then, again, the diet's as least restrictive as possible. In practice, I probably now very rarely do a full elimination diet. There's something that's called a modified low FODMAP or FODMAP gentle, and this is where we can kind of cherry pick 1 or 2 of either the categories, or we can cherry pick specific foods after a patient's gone through their diet recall that we think maybe there are some symptoms that are related to that, and then we can observe how that goes. Next slide. So when you compare some of the diets that are out there, they've found that compared to kind of a usual diet, that a sucrose and starch restricted diet and a low FODMAP diet are more effective in reducing IBS symptoms compared to a usual diet. And they found that an IgG exclusion diet and a healthy diet did not prove to be significantly more effective than a usual diet. And an IgG exclusion diet is a diet that's based on food sensitivity testing. So there's some tests out there, I won't name names, but some people have probably heard of them. They're very popular. And just to show that those don't have good evidence behind them and sometimes can be more restrictive than they have to be. Next slide. A lot of the times, fiber adjustment is needed, partly because going on to a gluten-free diet, sometimes we're including fibers that we weren't before, or we're including less fiber. So sometimes this is a big part of symptom management. Some people may need more, some may need less, and some may need different types. So an interesting study showed that there were 7 patients who were put on a low fiber diet, less than 11 grams, and every single one of them developed GI symptoms. 2 of them were also diagnosed with SIBO after that time frame. And then there is some research that consuming fiber with protein at a meal can help lower hydrogen sulfide. So this is not talked about a lot, but hydrogen sulfide is a gas that can be produced that can cause symptoms and diarrhea. And then we may need different types. So with fibers, there's fibers that are soluble, insoluble, fermentable, not fermentable, viscous, non-viscous, and many foods have lots of different types of fibers in them. So it can be tricky to pinpoint, okay, I'm going to eat just soluble fiber foods or insoluble fiber. Usually it's a little bit more challenging to do that. So sometimes we'll use some fiber supplementation in that sense. One other thing that I do want to mention with the fiber adjustment piece of things too is, especially for patients with non-celiac gluten sensitivity, there's been some research recently that found that the majority of patients were actually having symptoms related to fructan, which is one of those carbohydrate fibers that's in wheat and not the gluten protein. So I find this really interesting because a lot of people think it's a gluten sensitivity, but maybe it's not, and maybe it's a fructan sensitivity, and there are other foods within that fructan category that maybe people are reacting to.
5 minutes, Christy, 5 minutes.
Next slide. 2 types of supplementation that we can do fiber-wise, like I was mentioning, partially hydrolyzed guar gum. This is very soluble. It doesn't ferment a lot. It can be really well tolerated. It's a very regulating fiber, so either for constipation or diarrhea. 5 grams a day for 10 days, improved eradication rates, along with antibiotic therapy, and it also lowered methane levels, and high methane can be associated with constipation. The other type of fiber that we often supplement with is called psyllium. And again, this is a really good regulating fiber. It's also a soluble fiber, and it has lots of positive properties that can be helpful for symptom management. Next slide. So when you Google SIBO diet, you're going to find all sorts of different things pop up: low fermentation, low FODMAP, SIBO biphasic, specific carbohydrate diet. There's more than this. Next page. But the 2 you'll see most are probably the low FODMAP, low fermentation. So the low FODMAP diet is sometimes used when a patient is either before, during, or after a patient is diagnosed with SIBO. It can be helpful for symptom management, either before, during, or after. There is some research that it lowers a bacteria called Klebsiella. Klebsiella was recently found to be one of the most common bacterial species identified in patients with SIBO. So there's some interesting newer data there that maybe that's why it can be helpful, but there's really no good published evidence to show that a low FODMAP diet can be used for treatment of SIBO. So we just want to be careful that that's typically not the only thing we're going to do to treat SIBO. Next slide. There's also this low fermentation diet. I just wanted to point this out because I think it's popular, but there are no studies at this time that have assessed the low fermentation diet. It restricts high carbohydrate foods, foods that are not well digested and might be digested by bacteria. They do talk about meal spacing, which I think is important, but this may include lots of high FODMAP foods like garlic, onion, peas, white wheat bread. Obviously, if we have celiac or gluten sensitivity, that wouldn't be in the diet anyways. But so I don't use this often. And again, there's no research to really support the use of this in the treatment, at least. Next slide. Elemental diet is another one that can be used. There's some small studies that show that it's been helpful, one case report, and then one slightly larger study, but with the larger study, they found that after 15 days, it lowered the level of bacteria and patients had a negative breath test for SIBO. But then they found that it came back again for many people. And then a month later, they tested and there was still some symptom improvement, but some people had higher levels of methane after that. So there's also another study that I didn't include on here that after doing the elemental diet for 2 weeks, sometimes the levels just return back to normal right after stopping it. Next slide. The elemental diet also is costly. We also want to consider the social aspect of it. It is a full liquid diet for at least 2 weeks. So patients are not going to be eating, chewing, socializing with eating. They may feel really triggered or afraid to reintroduce real foods afterwards. The taste can be a challenge. And then there can be some risk for weight loss and inadequate nutrient intake as well. Next slide. I'll touch briefly on probiotics for SIBO and intestinal methane overgrowth. So there are 2 very specific probiotic strains that may be helpful. One of them is Lactobacillus reuteri for methane, and one of them is S. boulardii for hydrogen. So they found that with including S. boulardii with rifaximin for a treatment of for SIBO, that helped to improve eradication rates. And then the L. reuteri was shown to help lower methane levels. One thing we want to think about with probiotics is we want to make sure that it's really strain specific. We want to make sure there's research behind it for what we're using it for. We also want to make sure that it doesn't have prebiotics in it that may cause symptoms. So many have inulin added to them, and sometimes inulin is not well tolerated. And then again, we want to make sure that it's the right type. There are over 500 bacterial species that can be in probiotics and tons of different mixes within that. So we just want to make sure we're using the right one for the right reason and in the right patient. Next slide. So with all of this, the ways that we can help with IBS, SIBO, we can think about mindful eating, slower consumption, making sure that we're having regular meals, chewing well, careful use of elimination diet, working with the patient to improve diet variety, and then helping to modify fiber content or guides on supplementation of fiber. Next slide. This is a list of where you can find a dietitian that knows about either celiac or other GI disorders. And next slide. That is it. And those are resources. Thank you.
Thank you so much for that overview. That was really wonderful. I'd like to now introduce our third speaker for today, Dr. Jocelyn Silvester, MD, PhD. Who's an assistant professor of pediatrics at Harvard Medical School and director of research for the Celiac Disease Program at Children's Hospital, BCH, and associate staff at Beth Israel Deaconess Medical Center. She also maintains a general pediatrics practice in northern Manitoba and Nunavut through the Ongomiswin Health Services J.A. Hildy's Northern Medical Unit. Dr. Silvester is co-chair of the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, NASPGHAN, Celiac Disease Special Interest Group, and serves on the American Gastroenterological Association Council for section on basic and clinical intestinal disorders. Her research interests include the diagnosis and management of celiac disease, with a focus on what happens after the diagnosis of celiac disease is made. She is co-investigator on the Manitoba Celiac Disease Cohort Study, involved in clinical trials for alternative therapies to a gluten-free diet, and is leading a consortium of pediatric celiac centers across the United States to develop tools to improve follow-up care.
Thank you for the kind introduction. I'm very excited to talk about this topic, and I'll have to confess that when I first got the topic, it actually made me think a little bit. and wonder, well, what are the treatment targets in celiac disease? So we'll start with that. Sorry, can you see my screen? Oh. And then we will talk a little bit about some of the various options for treating celiac disease. So to start off with some disclosures, I'm involved in some consulting, some clinical trials, and then some various forms of research. I will note that I will be discussing off-label use of medications in this talk. And that will be really in section 2 when we talk about tools that are used for celiac disease. But first, I wanted to think about what are the things that we have as physicians that we can use to make patients better. And I think if we think in broad categories, there's sort of 3 things that we can do. First of all, we can treat symptoms. And this is really the essence of making patients better, is to make the headache go away, to make the diarrhea stop, to make the vomiting stop. And often these are treatments that aren't really very disease specific because many diseases can cause the same symptoms. The other thing we can do is we can treat damage from disease. So if there's a broken bone, we can splint it. If there's inflammation, then we can treat inflammation. But we aren't necessarily treating the disease, we're just treating the inflammation that the disease is causing. Or if it's something that we can cut out, we can do surgery and fix it. Like an appendicitis, we can treat it by taking it out. Now, what's more difficult is treatments for diseases, which are sort of akin to cures. And so these are things where you can treat the disease and the disease is completely gone and treated and cured. And I actually had a very hard time coming up with a very long list for this slide. And I think that tells you a little bit about where we're at with medicine, even though we're getting ever greater tools. And really antibiotics for infections were the great cure of the 20th century. And when you treat infections, eradicate them. Clot busters for blood clots have been also very important. And then now we're starting to see gene therapies, which are successful for some diseases where you can replace what's missing. And stem cell transplants are sometimes helpful if it's the blood cells that need to be replaced. But generally, we don't have treatments for diseases. And so when we think about celiac disease, we do have treatments for celiac disease symptoms. And those are many of the ones that I listed already, because there's so many different symptoms you can have from celiac disease. And so many of these medications can be repurposed for celiac disease, even though they're not really thought of as a, quote, celiac disease medication. Now, when we think about tissue damage, it's important to think not only about celiac disease, but to think about dermatitis herpetiformis as well, because different areas of the body are treated in different ways. And so for celiac disease, if the concern is that there's persistent villus atrophy, then one of the options is to use open capsule budesonide, which sometimes can help with healing. If the concern is malabsorption, then this can sometimes be overcome by supplementation or giving more calories if it's a calorie problem, or bypassing the gut entirely if it's needed in severe cases. If it's bone disease, it's a problem secondary to the celiac disease malabsorption, then there's also treatments for that. And then we have somewhat parallel treatments for dermatitis herpetiformis, where we can get to the inflammation more topically. Now, why a drug for celiac disease? And I think this is a question that has been asked a lot and is, if you think about it, interesting, because celiac disease has been around and we've known about it. We've known about a gluten-free diet for pushing 100 years now. And it's only been relatively recently that there's really been a lot of effort into actually getting a drug for celiac disease. And so I think right now, if we think about very early treatments for celiac disease, if you think about Sidney Haas and his banana diet, you could completely eliminate gluten, and that would be a very good treatment. But in reality, people are eating a variety of foods that have a little bit of gluten in them. And so there's some skeletons in the gluten-free cookie jar, which is why the glutenometer is not on a 100% gluten-free diet. Now, the other end of the spectrum is, could you have somebody with celiac disease be able to eat a, quote, normal diet with high amounts of gluten? And so I think when we think about these two applications, we come up with 2 different applications for drugs. So one is, if we know a gluten-free diet is not free of gluten, can we do something that's going to make the gluten-free diet more gluten-free? And then alternatively, can we do something that's going to allow a normal diet? And these in general fall into 2 categories, where one is looking where the first ones are often targeting the gluten and the second ones are targeting the immune system, which is actually the effector of the disease. So this is a figure of the intestine at the top here with the croissants and the food is the lumen. And then this is the epithelial barrier. And then you have various inflammatory cells here. And you can see again that you have gluten, which is the triangles, and it's being digested by the tissue transglutaminase. And then that makes it more readily presented to the immune system, which instigates the reaction. And so there's many different targets. And again, they fall into these two categories. And actually, if you think about it, a gluten-free diet, although it's not a pill, is really a treatment to decrease the toxicity of gluten to people with celiac disease. And then you can also, there's also efforts to edit the wheat. There have been efforts to try and bind gluten so that it stays in lumen and can't get accessed by the rest of the body. There's efforts to break down the gluten, and then there's efforts to inhibit the tissue transglutaminase so it doesn't make the gluten as readily presented or as strongly presented. And then on the other side, there's preventing those those immune cells from actually showing the gluten to the immune system, so it becomes somewhat invisible, or they can see the gluten, but they don't react in a harmful way. And so this is the same picture again, and these are some of the drugs, and I'll give you a list on the next page, but essentially we have some glutenases over here that are targeting really high up. We have medications that are targeting the tissue transglutaminase. We have medications targeting crossing the barrier. We have medications targeting the inflammation, and we have medications targeting the immune recognition of gluten. And so what's exciting is that there is a pipeline, and there are multiple medications that have multiple different mechanisms, and there's many companies involved, and there are small companies which have a proprietary product, as well as large companies which are starting to get into the game, which I think is probably exciting and showing that the field is maturing and that there's more effort to actually get across the finish line. So I wanted to focus briefly on two medications. The first one is Z1227, also known as TAC227, and this is a TTG inhibitor. And Dr. Therrien already talked about TTG, and TTG is really important in celiac disease because it partially digests gluten, and that makes it easier for the immune system to present. And we know that there's something about once people with DQ2 can present gluten, then when you give them gluten, you start to drive the reaction. And so if you could prevent the gluten from binding, then perhaps you could stop all the downstream effects. And so in order to test this drug, we need to know if it works. And I think this is one of the other really interesting things about celiac disease is that the drug development pipeline is a little bit different because right now, though we don't have a drug, most people are actually on a treatment. But the treatment, because it's not a drug, is highly variable. And it's hard to know exactly the intensity of treatment that people are getting. And most people who are on a gluten-free diet don't endorse a lot of symptoms. And so if you have a relatively healthy population, how do you develop a drug for them if you are not going to put them all back on gluten? And so usually we take sick patients, we randomize them, we give them a drug or placebo, and then we see if we've made them better or not. In celiac disease, we're starting with a bunch of patients, and this is the patients they picked for this trial, 163 adults, well-controlled celiac disease on a gluten-free diet. So you take treated patients and you randomize them to the treatment or to placebo, but then how do you know if they're getting better or if the drug's working? And so in this particular clinical trial, they added some gluten during the treatment period to see whether or not the drug and the placebo groups responded differently. And their endpoint was looking at histology, small intestinal biopsy. So this trial has been published, and this is what the design was to take the adults with healthy villi, randomize them, do the treatment period, and then follow up. This is the data. And so the blue line is placebo, and then the colors are the different doses. On the left is the villus height crypt depth ratio, which is a measure of how tall are the villi, how atrophied are they. And then on the right is the intraepithelial lymphocytes, or the inflammation measure. And these don't always track together, which is why they looked at both. And what you can see on the left is it looks like the placebo group, their villi got shorter, whereas the others stayed pretty the same, and inflammation tended to increase most in the placebo group and maybe was a little bit less in the high dose group. Now, of course, it all looks very good when you look at averages, but when you get into real life, it's a little bit more tricky and complicated. And so this is a look at the raw data, which I think shows some of the challenges where we have many people having different degrees of differences, and the actual differences we're seeing are perhaps somewhat small. But overall, if we looked at the population, we are seeing that the patients who had the drugs didn't have as much decrease as the ones who had placebo. The other approach is to try and get these T cells, when they get presented gluten, not to react in a harmful way. And so one of these medications is CAN 101. And the idea here is that if you can add a carbohydrate to the gluten, then it gets taken up by the liver and it gets presented in the liver in a way where when the body sees things, it should tolerate them. Just like if it sees a protein that's a body protein, it shouldn't respond negatively. And so if it finds those T cells that get activated from that protein, it then reprograms them either so they do nothing or that they kill other T cells that recognize that. And so that can potentially help you tolerate the gluten, because now your immune system isn't reacting to the gluten in a negative way, and those T cells that react negatively are being gone, or at least that's the theory. And so this is a bit of a different clinical trial design because they're taking the same thing. They're taking healthy adults who are well controlled, but now they're looking at, all right, did we change the response of the immune system? And so instead of looking at small intestinal biopsies, what they did was they gave people a dose of gluten and they looked for immune response. And there's two ways that they use to look at immune response. One is to look for release of a cytokine, a chemical signal called interleukin-2 in the blood. And the other one was to look for release of interferon gamma in blood that had been challenged outside the body. And what they found in both cases was that there was more of an immune reaction in the placebo groups than there was in the drug groups, suggesting that perhaps the drug had some protection against responding to gluten. And so this is a very early phase trial, small numbers of people, and there's a lot of questions, but there's a signal that perhaps there's something here and that we're able to create some tolerance. So another thing that was interesting about this is that this drug is actually cleared relatively quickly, but it was some time before they did the challenge, and they still saw there was some protection. So in summary, treatments can be for symptoms, they can be for tissue damage, or they can be for diseases. And although there's no disease-specific treatments for celiac disease, we do have tools that we do use for symptoms and for tissue damage. And that there are drugs that are being developed for celiac disease, and some of them are targeted towards tolerance and potentially allowing people to tolerate gluten.
Great. Thank you so much for that wonderful overview of the upcoming therapies. We'll next move into our Q&A session. Just let everybody know we will be staying a few minutes beyond 2:15, just given our late start time. And thank you to all who submitted questions ahead of time and who submitted them through the Q&A function. All right. So to get things started, there was a question about how common it is to have an elevated TTG IgA level and not have the diagnosis be celiac disease. Dr. Therrien, any thoughts on this?
Yes, so I would say it all depends on the degree of elevation of the TTG. Like I mentioned before, when you have higher than 10 times the limit of normal, meaning you are above like 100, 200 in your TTG titers, it's very unlikely that it is not celiac disease. It could happen, but it will be very rare compared to if you are just at the limit. Let's say the limit is like 15 and you have 17, you have 20 in terms of like your levels. Laboratory errors like problems with the assays at the lab is always something that can happen, and also the other like infection, inflammatory conditions. So there are data from the UK in which like 3 to 5% of their mildly positive TTG were not associated with celiac disease. And when it's a population that also has like autoimmune liver disorders, other autoimmune diseases, it can go up to like 30% of people that have just a mild elevation of the TTG, and in the end, it's not celiac disease.
Perfect. Thank you. And then along those lines, if a patient has no genetic markers for celiac disease, but does have elevated antibodies in a positive biopsy, would you consider this individual to truly have celiac disease, or would you consider a different diagnosis for them?
Yes, I wanted to answer that question because there's a question about what type of like gene test they have done. There are some commercial at-home tests that only look for specific like common polymorphism of the gene. So yes, those tests can detect, let's say, 95% of people that are HLA-DQ2 or DQ8, but some can be missed, compared to have the gene testing done in a hospital setting where there would be a full like haplotyping of your DNA. Then we will know for sure that you absolutely do not have any bits of the genes that could be associated with celiac disease. So in general, when I see that discrepancy, I question like what type of gene testing was done. And I've seen very, very, very rare cases of other types of like autoimmune enteropathies that were having positive blood work and biopsies that showed inflammation. They were not responding to gluten, and it was autoimmune enteropathy. But these cases are very rare. I only seen a few.
And then a similar question. So can Giardia cause villus atrophy? And so would you question a diagnosis of celiac disease for someone who may not have active Giardia, but recently completed treatment for Giardia?
So in my slides, Giardia was part of the type of infections that can cause villus atrophy. And yes, with that type of inflammation, could there be a little bit of elevated antibodies? Possibly. I would say in this scenario, I will repeat the blood work. And if the person is still having symptoms, consider repeating like endoscopic exams a few months after the end of the treatment to see is there still like remaining inflammation? Is it like, in fact, does the person has both like Giardia and celiac disease, or was it all like just Giardia?
Thank you. And to shift gears a little bit, we had a few pediatric specific questions for you, Dr. Silvester. So one was if a child is diagnosed with celiac and at the time of diagnosis has a TTG-IgA that's 10 times greater than the upper limit of normal, they're diagnosed with duodenal biopsy and they start a gluten-free diet and follow it strictly for 3 years, and you're repeating their serology and the TTG is much improved, but is still a little bit above the normal level. How do you kind of interpret that at the 3-year mark, and what advice do you have for the family?
That's a great question. And I think the first thing I do is talk to the patient and find out what they've been doing, because we know that in most patients with celiac disease, the TTG antibody level is being driven by gluten. But we also know that after initial diagnosis, there's a washout period and it takes time for it to go back to normal. So in this patient who's been on a gluten-free diet, who started with a super high level and has never normalized, it's always a question of, are they still on the pathway? And often it plateaus before it gets and crosses back into the normal line, or is it still up for a reason? And is that reason gluten, or is that reason something else? And so usually at 3 years in patients who've had a super high level to begin with, I try and get them to meet with a dietitian so that we can identify if there's gluten. But often I find time will see that antibody level go down. And so I try not to jump in and biopsy right away, because often what we're seeing is just a prolonged washout.
Perfect. And similarly, specifically, this question was about in pediatrics. We know that it can take time to see healing of the mucosa after initiating the gluten-free diet, and that in most cases, but not all, GI symptoms and other symptoms get better with time. What advice do you give for families for managing symptoms in the meantime, as it can sometimes take on the scale of weeks to months for those symptoms to improve? Are there other strategies they can try?
That's a good question. I think, partly implicit in that question is a question of at what point do you say, all right, this person has celiac disease and they also have a symptom that is associated with celiac disease, but for them, that symptom may not be a sign of celiac disease. And I think that's where it gets more complicated because often, as one of my patients put it not long ago, this symptom was what got them diagnosed with celiac disease, but it wasn't the celiac disease. And so now we have to find another cause for that symptom. And so I think the overall trajectory, is it changing? Is it improving at all? Is it getting worse? Is helpful in trying to differentiate that. And I did mention in my talk that, we do have symptom targeted therapies, which are somewhat, unsatisfying sometimes because it's not getting to the root cause, but Band-Aids are helpful. And especially if it's something where we think it's related to healing and we know the healing is going to take a little bit more time, but it's happening, then that's what Band-Aids are for. So I think it's a balance of being certain that what we're treating is celiac disease and that waiting is appropriate, and then using the tools we have available or looking for another cause.
Thank you. And similarly along those lines, Christy, we had several questions about dairy and about lactose. So if you could speak a little bit as to why many people feel that they are lactose intolerant at the time of diagnosis, and if that gets better for many people with time.
Yeah, sure. Yeah, and I think Dr. Therrien may have mentioned this in the very beginning. So the little finger-like projection villi, that lactase, which is the enzyme that breaks down lactose, is right at the tip of the villi. So if there's damage in the beginning, you may have an intolerance to lactose because there's a lack of that enzyme. Very often, as celiac disease improves and as healing improves, there can be better production of lactase and then therefore better tolerance of lactose. So that's part of it. The other part of the dairy piece, I think this was also a question that was submitted previously, is there a possibility of the milk protein? And there are case reports of milk protein, especially in kids. I think the case reports were all in kids, of that causing continued elevated TTG and intestinal damage. And when they removed the milk protein, they found that people responded well to that. The good news with that is, at least in 2 of the case studies, I don't know if it even mentioned it in the 3rd, but in 2 of them, 18 months later, they were able to add back that milk protein and tolerate it and not have it cause damage. Whereas with the lactose, that's not going to cause damage. It's more of a symptom management. So some people can take a lactase enzyme and tolerate it. Some people can tolerate small amounts. So it can be a bit of trial and error with that.
Perfect. Thank you. Thank you. Shifting back to some of the non-celiac disease conditions that can cause similar symptoms, Dr. Therrien, what would you recommend for patients is the best way to determine if symptoms are secondary to their celiac disease or something else like IBS or potentially SIBO, and when to approach their physician to discuss that?
Yes, so we mentioned a few conditions on the talk. Usually we start being looking more for other conditions after like 3-6 months on a gluten-free diet, and like I mentioned, considering an endoscopy more after 12 months on a gluten-free diet. So it's a combination of like evaluating with the diet, what are like other potential triggers with the dietitian, evaluating with the GI doctor, like how are the bowel movements, constipation. Sometimes we do like breath tests for SIBO. We can do stool tests for pancreatic insufficiency. So I would say usually it's after this 3 to 6 months mark. But we had some questions about like differentiating between IBS, SIBO, celiac. So one of the main thing with IBS, in general, it causes like some pain. This is part of the diagnostic criteria of having irritable bowel syndrome. So yes, sometimes we can do like breath testing for SIBO or trying like empirical like rifaximin. And then after that, if there is still like a pain component that does not respond to antacid, because we also mentioned that reflux, like peptic duodenitis, can be something coexisting, and also there's no like considerable constipation. Then by process of like elimination with clinical criteria, we go more towards like IBS with visceral hypersensitivity.
Perfect. Thank you so much. And I think that's about all the time we have for questions today. Thank you again to everyone who submitted the questions and to all our panelists for staying late and answering many of them. I'll turn it back over now to Chris Rich. Thank you for having me.
Thank you, Dr. Olshan, and thank you to all of our presenters and attendees for your participation. We hope that all in attendance found this webinar educational and helpful. Remember, for those of you who have registered for continuing education units, go to the link that was sent in the chat box and fill out the survey. Please watch for announcements about our next edition of the National Celiac Association, Harvard Medical School Center Celiac Education Research Program webinar series, which will happen in April of 2024, and it will cover heart health and weight management in celiac disease. You can visit our websites and watch our social media accounts for updates. So from all of us here, we look forward to seeing you next time, and thank you for your continued support.